So I think what you're really asking me, the minimal access surgery, and does really size matter? I suppose what has happened in gynecology and throughout many other surgeries for the last 5 to 10 years is we are actually, with the use of technology, we can do lots of complex operations using minimal access, which means making tiny, small incisions and doing the same operation what we used to do by being a big cut in the abdomen. But one of the problems with giving a big cut in the abdomen is the recovery is significantly delayed for the patient. So by learning these new techniques, we can actually do, for example, in gynecology, the commonest procedure still done is hysterectomy. So the question is, how can we do that as minimally invasive as possible? So there are techniques which I personally use, such as laparoscopy or robotic, and by using those techniques, my open rate for hysterectomies is less than 1%. We've published on that. And there are still many patients across the country, globally, who are still having open operation because they have been told this uterus is too big or they have high BMI. But actually, if you use the techniques and if you're trained properly, you can actually do all, even highest, very large uteruses or even high BMIs using these laparoscopic or robotic techniques. So size really does not matter, but it is the proper assessment of the patient and using the proper technical tool which matters. So I have taken largest uterus out, which is nearly 7 kilograms, which is quite large, but it's how you take it out. And how you use your tools you have, such as robotic assistance, but especially if you have a larger patient. So currently, if you see, although laparoscopy is quite in now for laparoscopic hysterectomies, but it has got a downside when it comes to high BMI patient. When you reach BMIs more than 40, it can become challenging and difficult, and therefore it is published that the conversion rates are high, means you end up opening a patient because you cannot complete the procedure laparoscopically. However, if you use a robotic assistant in those cases, we can still use the robotic assistant to help to manage those patients who have got high BMI. And unfortunately, there are still lots of patients who have been referred to me over the years who have been denied of having any operation. Especially if they have a benign cause, they've been told because they can't have it because they are big, and of course their complications can be high, but it's really how we assess. So yeah, no, size does not matter if you have a proper assessment and proper tool and use that for the patient. So again, as I said, it goes back to the basics first. Is assessing the patient properly, listening to the patient properly, diagnosing the patient properly. So why are we doing these operations? For example, if patients have simple heavy periods and no other pathology, then we actually use outpatient procedures such as Mirena coils or ablation. They don't even need a hysterectomy. However, if they need a hysterectomy, that means they have got some other pathology. For example, benign causes, they may have extensive endometriosis, or they may have, if there's malignancy, they may have cancer. So then basically is, how do we assess those? So it's for example, if you have a cancer patient, we don't want to be, so when we understand, when we say minimal access, yes, we can put what we call them ports, instruments in to separate the uterus or big ovarian cyst from the patient, then we have to decide how do we take it out. Because although our incisions are very small at this time, but we need to then have a plan how to take this the specimen out. And this is where the pre-op assessment comes in. So if, for example, we have a patient who may have cancer or suspected, then we don't really want to, what we call, morcellate the specimen. But however, we can still do minimal access in the sense we can separate the uterus from the patient, and then we can do what we call is a low transverse incision rather than a big midline incision to take the specimen out. So it's almost like a cesarean section. So patient will still recover within 4 to 6 weeks as compared to 3 to 6 months if they had a big midline laparotomy. So that's how we enhance the recovery, is basically getting them away from these big midline laparotomies. So if you open somebody just what we call as laparotomy, had a cut in the abdomen from your, maybe belly button down, and did nothing else, that scar will actually take at least 6 months to heal to its previous strength. So by avoiding that big cut in the abdomen, you are automatically enhancing this patient's recovery. So you're minimizing that. However, so as I said, instead of doing the midline, you can actually even do the transfers like cesarean section to remove that specimen intact, even if you don't morcellate it. Whereas in benign case, if you had assessed this properly, we have got instruments which we can morcellate safely in the bag and also avoid the risk of spilling. So there are techniques which we can do so that these patients can recover as soon as possible. The majority of my patients will actually go home next day. Majority of them will go rather than 3, 4 days or 5 days. Yeah. I think probably I did say before, I don't think it's size which really matters. It's the indication which matters. Obviously, you need to have, when it becomes more complex, so you have a high BMI patient, you have a high mass, you need to have a multidisciplinary team to support you because they can have anesthetic problems, they may need an SGU support. So it's why do we need to do this operation? Have we given all the possible treatment options which can be avoided? And I think once we've done that, and this is the only option, then size really doesn't matter as long as we have assessed the patient properly, patient's counseled properly, and we have got the setup what we need. So I work within a multidisciplinary team, both at laparoscopy and robotic. So have the team what I need to do these procedures safely. Again, it's minimal access. It's either laparoscopy or robotic. As I said, depending upon what their circumstances are and how we can remove that specimen. But again, comes back to the preoperative assessment. But I think it's saying, do we actually need the operation first? Have we done what we need to do preoperatively? Because there are other medications we can use, but large uteruses, if everything has been done, we need to do, and I think it's much easier to actually do as compared to open operation because your risks are less. We can actually see so far better than our own eyes because with the technology using the laparoscopy or 3D laparoscopy or the robotic assistance, the vision is massively improved as compared to our naked eye. And we actually don't use our hands in the patient's abdomen. For even with the robotics, they resemble our hands, but we are actually working remotely. So we are actually getting the same advantage what we will need, but actually we are actually minimizing one of the main complications with the bigger uteruses is the bleeding, because the blood supply to the uterus is quite significant. And then those blood supplies come from the side walls of our pelvis, what we call it. And then there we have the tubes which come from kidney to the bladder. They are very, very close. And that's why if you look at the literature, one of the commonest complications of hysterectomy is bleeding and ureteric injuries. And that's, but if we have techniques which I use is identifying those ureters safely first, and then identifying the blood vessels, trying to take those first, we reduce the risk of complication, reduce the risk of bleeding. And then we separate this uterus, and then we decide how we're going to take it out. Again, I use different techniques to take it out, but certainly I would say it's far better to use either laparoscopy or robotic assistance rather than open operation, because you only increase the complications to the patients. I think it's probably I'm repeating myself, but again, it is a preoperative assessment. It's understanding what operation is. And we do prepare in case we have to open. So, and obviously, I think it's raising the expectations. The norm is we will hopefully complete the operation laparoscopic or robotic, but very occasionally we have to be prepared that we may have to open. So usually they will have some family support to support them post-operatively, but significantly majority of my patients will go home next morning, will not need any additional support except for what we ask them to avoid heavy lifting for 6 to 8 weeks, because especially if they're having total hysterectomy, when we suture the top of the vagina, that has to heal. And if we do strenuous exercises, then there's a risk that that cannot heal properly. For rest, we don't, certainly my patients will actually go back to driving within a week or 10 days. Once they are comfortably able to sit, they're able to put the seat belt on and they can do the emergency brake. They can do the normal routine except for heavy lifting. So I think it's really appreciating what they can and they can't do. It's mainly they can do their normal routine except for heavy lifting, and they can go back to work within 3 to 4 weeks, depends upon the circumstances. I think one has to understand is every patient is different. There is no set time for one patient. But in cases, if we do have to open for whatever problems there might be, then their stay may be, rather than overnight, they may be 2 to 3 days in a hospital, and the recovery is a little bit more delayed as compared to the minimal access. Again, I think it's just if you compare the open operation to keyhole surgery, the recovery is straight away. You're not in that much pain. You're not requiring that so many analgesia, because one of the advantages of keyhole surgery is that post-operative pain is less, simply because we have performed the operation. Especially, I'm very meticulous when I do the operations. I don't leave any blood behind, because when we leave blood behind in the abdominal cavity, it works as a very irritant. So it causes adhesions, it causes pain. So when you really take your time and be meticulous, make sure your blood loss is very minimal. And we do what I do is called avascular dissection. So the blood loss during the operation is really very minimum. And when you have an abdomen which is pristine, you leave it neat and clean, the post-operative pain is very little. So they're not actually taking too many analgesias, because if you take analgesics such as morphine, you're going to get constipated and you're going to have bowel problems. So that itself takes a longer time to recover. So it's really avoiding one of the enhanced recovery principles which I use and which have been shown to improve the recovery is we minimize putting catheters in, not putting any drains in, trying to get patients to eat and drink soon after the operation. So getting them feel normal. And because their pain is less, they really feel so comfortable. They are able to go home next day and they can actually see the difference. And the recovery is so much significantly improved as compared to if they had an open operation. And then obviously that's quality of life, because they're back to almost normal. They are back to work as quicker as compared to open operation. And overall, it's just, there is no disadvantage. If you're going to have an operation, then have it as a keyhole. But if you need if you have a problem, we try and do it without an operation to start with. But if you are needing an operation, then keyhole operation. And patients do travel, and I have patients travel from lots of other places to come to me because we can offer that. So because if you have to stay overnight, but actually you can go back next day and get back to your normal routine. You know, lots of people are working from home. They are able to work within a week, 10 days. So yeah, the quality of life is significantly improved as compared to open operation. And there is no need to have an open. Only certain cases, if you have a massive ovarian malignancy and think that's when it needs. But for other degrees, for example, endometrial cancer, there is no need to have an open operation. For benign cases, for endometriosis, for fibroids, for myomectomies, we all do it keyhole, either using laparoscopy or robotic assistance, depending on the patient, what they need. And yeah, size doesn't matter. If they're big patients, we can use robotic assistance, not a problem if the operation is indicated. And if it's a big uterus, not a problem. I can use the methods to remove it as a keyhole.